that where do we start from? I think not all cases are same. You open up an eye with PDR and every case seems to be different. So where do we start? Shall we start from center or periphery? Dr. Reddy is going to make us wiser.
Thank you, Dr. Devendra, for making me part of this course. This talk has helped me sort out my videos, and I'll be talking about how to find this starting point and right planes, so that you avoid the most problems in this most difficult surgery of all in vitrectomies. So where do we start depends on the status of the PVD, whether this previous PRP has been done, on the extent of tractional retinal detachment, and also when the PVD is present, the extent of PVD, the configuration of the PVD, and the areas of attachment, strong areas of attachment of this PVD, and the strength of these adhesions. So these are the tools that probably required to handle all diabetic vitrectomies. I don't think cutter, that will be a 25 gauge cutter, the forceps, scissors, PFCL, brilliant blue and chandelier. I don't think will require any further, and of course a spatula, 25 gauge spatula, which I'll be discussing. Spatula is one instrument that is very fond of, and it's avoided. It helps in finding the right planes, make space so that your cutter can be inserted, and it can avoid bimanual surgery in fair number of cases. This is a 25 gauge, available 25 and 23 gauge, and previously visco dissection and all things are proportional reflex. These are the things that have become redundant if you have a spatula in hand, and that can help you in all. There will not be need for these proportional reflex and visco dissection. This is another, sometimes during the bleeding and all, if you do an interface vitrectomy, you'll again find the right planes where you can to help visualize the vitreous. As you can see, the vitreous gets highlighted like this, the work under air, and you realize that is area where vitreous is left behind, and you can do more vitrectomy at that place. So in between, during surgery, if you switch to air, that will help you identify the planes of the surgery. And brilliant blue is something that is that stains the ILM as well as and also the vitreous. So if you use liberally during your surgery, it's also a good thing that can make your life easier instead of triamcinolone, because this stains the ILM as well, and so you have the double advantage with brilliant blue. And when you're planning for surgery, it's important to know where to start and also which membrane to handle last. So in this kind of membrane, this is the membrane that you see down, that is where probably you'll require bimanual surgery. So it's better you handle that last and finish all the membranes and then come to finally to this membrane. So instead of trying to directly go and trying to remove the densest membrane, most adherent membrane. And starting at the disc, when there is no retinal detachment surrounding it, is the most best place to do your dissection. And then, but there are many other ways in different case scenarios. So it's always good to go and try without any premeditated surgical behavior. And it's always good to know that when there are large membranes like this, it's good to divide them and handle each membrane separately rather than trying to do en bloc dissection of all the membranes together. So if you can divide these membranes into multiple 4-5 pieces and then handle each membrane differently, that will be more easier. Even if there a break happens in handling of membrane, it is limited to that particular quadrant, and the rest of the surgery in the other quadrants of the retina is not so affected. So if you can divide and then proceed with dissection of the membranes, that's the better way of going rather than en bloc dissection. So, this is the other small thing that I was saying is this lawnmower approach. When there is when you don't have any purchase behind a membrane, broad membrane like this, and an adherent retina is not detached. And if it is a detached retina, I know we have to go to bimanual surgery. If it is attached retina and there is a broad dense membrane like this, and we don't have any purchase of going behind the membrane in these cases, this is these are the kind of situations where you would try to do a lawnmower approach. You keep your cutter tip just at the membrane and then take it horizontally across the membrane and cutting the membrane into half. This is what doing all the instruments, but we cannot get any enough purchase to go beneath the membrane and remove it. Underlying retina is relatively flat. This is when we would use this, like how we seen. Yeah, and this is where you put the cutter at the edge and just try to take it through and dividing the membrane. Once the membrane is divided, it's handling the other two pieces of the membrane is relatively easier. Okay, now this is a case where we'll be starting experience about how to start. This is a case where you do not see any anatomical landmarks. Where is the disc or the macula? And intraoperatively, the only way you can find out is this yellow pigment where it is there, relative on the few meters away. You probably guess there is a disc, and that's where you start your dissection. And by pulling the membrane above and then putting a small PFCL bubble. And this is a spatula being used to make way for the cutter so that it can to know that there is the clear route, and then start your dissection. So in this way we can when there are no anatomical landmarks, macula, and then guess where the disc is there and then start the surgery. This is the post-operative appearance of the relaxing retinectomy is required. This to it is released, and is again we have to cut this membrane into pieces so that the handling, the dissection becomes easier. So this spatula being used to make way, and then the membranes are cut, and then now these two membranes again will require a bimanual surgery. This is a post-surgery of the same patient, and PFCL spatula and cutter assisted delamination is the best way to this complicated membranes. And when the purchase is when you cannot get behind the membrane from posterior anterior, you can try from anterior posterior. If there is a space in that direction, and then go ahead. Idea is to keep bimanual surgery, avoid bimanual surgery as much as possible. That was how I used to do. And this is a cutter opening, can be done with the hyaloid. If you do not have enough purchase with the forceps, you can find the edge at one place here, change the cutter direction, and then hyaloid can be opened with the cutter like this. If you do not find enough, and it's difficult to use the forceps in this patient because you inadvertently breaks nasal to the disc in some kind of cases where the adhesions are very strong. Yeah, there's a case of one-eyed patient. This is a tractional retinal detachment with membrane starting from the disc and going superiorly. It's important that when before handling the membrane, the vitrectomy is complete, and look for any vitreoschitic membranes and complete the vitrectomy. And this membrane dissection, you cannot start from the disc because you're likely you have to start from where the membrane is starting, from the inferior arcade, and then go towards the epicenter that is there superiorly. Inserting a PFCL bubble and helps in stabilizing the dissection. This is a post-operative appearance of the same patient, and this is the toughest of all cases where there is no PVD. So, and there is angry-looking new vessels, and there is tractional retinal detachment. This is the kind of cases would give an anti-VEGF prior to vitrectomy, and we start again from the disc, make an opening into the hyaloid, and then exchange. This membrane that you see temporarily, that again has to be handled last, and start with the PVD and finish extend it anterior to the entire retina, in all quadrants, and this particular membrane where it is there adjacent to the macula, that probably needs to be handled last, because if you go there first, because there is no PVD at all in the rest of the quadrant, and if some problem happens in that section, the entire surgery gets compromised. So once PVD is extended in all quadrants, and lastly we go to this membrane. And this is our post-operative appearance, and this is where I've discussed again. Yeah. Fine. So this is a membrane that we should keep it for bimanual surgery and not try to attempt doing it without bimanual surgery, and dividing and conquering the other smaller membranes using span. Yeah, this is another. I'll stop with this after this video. This is a case of diabetic treatment knife TRD, and with TRD and secondary regmentinous RD adjacently, and so in this is a kind of cases where you can safely induce vitreous detachment from the areas that are not detached. So the areas of the retina where the retina vitreous can be detached safely, aggressively, and then extended towards the optic disc, and then the surgery can be completed. Rather than starting from the disc, you can induce PVD safely from all the other quadrants, and then surgery can be completed. And this is again a case where this particular membrane has to be handled hard. There is no PVD in the rest of the retina.
Dr. Reddy, we are running short of time.
Yep.
They are good videos. Even we want you to continue, but in interest of time, we'll have
thank
to.
you.
And Dr. Jatinder, your take.
Excellent up here, but just in the interest of time, one technique that I follow is to use hard tip extrusion cannula. So this hard tip extrusion cannula can be targeted because you have a focused kind of traction at the vitreous, and choose the area where there is no traction, or there is very few fibrovascular stumps. And once the PVD is induced, sometimes the subhyaloid hemorrhage in that area can give you a guide. It keeps on extending, and it gives you a guide to the extent of PVD that is happening, and you can continue that towards the detached retina, and then start making one. The other thing that I do is make an opening into the posterior hyaloid as early as possible. So that gives you a resistance that the fluid that is going inside kind of creates a blunt dissection and goes underneath that true hyaloid space, and then can also give you a kind of third hand. Even without bimanual, sometimes you are able to complete the surgery. Dipinder, any points on you want to add? Yeah.
So what is your choice of tamponade, and when you decide about putting, like, in which cases you would want to put oil, or the cases sometimes you actually do a very good dissection where you tend to decide you'll put a gas, but you may have an indolent or a break which you have not seen. So, and at times these patients have a blood stain vitreous cavity and we actually not see the retina. And sometimes it may come after a month or so where you are actually seeing a detached retina. So what are the pointers you would want to think about?
Say regarding the tamponading agent,
Yes.
intraoperative hemostasis is good. I mean, towards the end of surgery, you feel there is no bleeding is happening, and then in that case we put in gas. In cases where we expect some amount of at the end of surgery there is some blood clot that you have left that is not removed, that you could not be removed. At that cases we put in silicone oil. Silicone oil is not just for the case of tamponade, it's for the case that they need to be visually be rehabilitated slightly early. So my choice depends on whether at the end of surgery it is clean, the field is clean, there is no bleeding and there is no choice, and all bleeders are complete. In those cases we put in gas.
So these sometimes because of some focal traction you would see the retina is elevated. So whether do you put in
No,
oil
they will
in
not
those
be
or
required to. If the
you
traction
feel
is
able to
relieved, I
detect it?
think all they'll settle with on their own with the gas. There is no need to put in gas just because there is some elevated retina. There is no retinogenous component. I think safely we can put in gas. Many of the times, in spite of being oil, many of the SRF is still there. At the time of oil removal, also sometimes SRF is still there. So having slightly elevated retina is not an indication to put in silicone.
I'd just like to add in that there are few surgeons who choose to do the surgery in 2 steps. So when you are dealing with the complicated cases that we are discussing today, always advise a patient that he might need 2 surgeries. And whenever there is like large sticky clots, you are not able to do a complete removal, inject gas and sometimes short-term PFCL tamponade, and do a lavage later on and then inject oil. The problem with oil is that with these sticky clots, fibrocellular proliferation, lot of traction, and then that contracture that will get into the retina. That intrinsic contracture of the retina is then going to cause breaks even if you do not have intraoperative breaks. And that becomes a messy affair later on.